Hello, everyone. Welcome. As you get signed in, you'll see a survey on your screen. If you can take a second to fill it out, that would be great. You can also drop into the chat where you're calling in from if you would like. We'll get started in just a few minutes just to allow for more people to get signed in. But as we wait, I would like to introduce myself. My name is Madison Burnett. I'm a BCBA. I lead our professional development program, and I'll be supporting throughout today's webinar. In addition to that role, I work alongside other BCBAs on our clinician-led recruitment team, helping to attract and recruit high-quality professionals to join our organization. If you are interested in joining MPG, please indicate so in the post-webinar survey at the end of this webinar, or you can email careers@manhattanpsychologygroup.com. I see we have about 60% of our returning attendees with about 40% that are new, so welcome everyone. We're thrilled to have you all. All right, on the next slide, you'll see a little bit about Manhattan Psychology Group. We were established in 2011, and we've continued to grow our team consisting of skilled adult and child psychologists, neuropsychologists, behavior analysts, special educators, licensed social workers, and behavior interventionists. If we can go on to the next slide, that would be great. As a team, we're committed to wraparound care, which includes our wide range of services from mental health and testing to ABA and educational services. We serve individuals, couples, and families of all ages out of our Upper West Side and Long Island City offices, in home, school, and clinic-based settings, as well as through telehealth. Our vision at MPG is to create a future where individuals and their families feel supported, connected, and empowered. And our mission is to provide a multidisciplinary, integrated support for individuals and their families who experience mental health, behavioral, and educational challenges. All right, on the next slide, you will see a little bit of housekeeping information for today's webinar. This webinar is eligible for 1 contact hour for New York State licensed psychologists and social workers, and 1 general learning CEU through the BACB. A link for the quiz regarding the content of today's presentation will be posted in the chat within the last 5 to 10 minutes of the presentation. As of January 1st, we have started charging a nominal fee for the continuing education certificates. This webinar is still free to attend, but to obtain a certificate is $10 for New York State licensed psychologists, $5 for New York State licensed social workers, and $2.50 for BCBAs. Any polls during this webinar are not required to get your certificate, but they are encouraged. We will be leaving the chat open, but please post any questions you have in the Q&A so we can make sure that they are seen. The button for Q&A can be found in the upper right corner of your screen if you are using a mobile device. Following the presentation, you'll have the opportunity to join a breakout room to network with other providers in your area. And now I would love to introduce our presenters. Dr. Joshua Rosenthal is a licensed clinical psychologist and Manhattan Psychology Group's founder and CEO. Dr. Ariel Kornblum is a licensed psychologist, board-certified behavior analyst, and licensed behavior analyst, and is MPG's Senior Director of Clinical Operations for Behavioral and Educational Services. And Dr. Francine Zelter is also a licensed psychologist and MPG's Clinical Director of Mental Health and Testing Services. And now, without further ado, I will hand it over to Josh.
Thank you very much, Madison, for the intro. It's good to see so many people here today. So what we're going to try to cover today are generally how to establish effective multidisciplinary collaboration using an ethical client-centered approach. We're going to get into the nuts and bolts, the complexities. We're into the nuts and bolts, the complexities of hiring and billing, and really the operational or the process challenges of doing this type of work. We're going to be talking mostly on a cash-based practice since we are cash-oriented, but we're also going to mention some opportunities for insurance-based advocacy as well. Communication is a big part of what makes a multidisciplinary approach work, and so we're gonna focus on that. And we're also going to talk beyond working with people with autism and how you can work with all different types of diagnoses across all different mental health continuum. Thank you.
Okay, good morning, everyone. So today on our agenda, we're going to talk a little bit about MPG, the company's growth, where we came from, and how we got into multidisciplinary care, a number of years ago. We'll also talk a little bit about just the foundational ways to set up multidisciplinary models, how they look, how to create a successful one, who are the members of the team, how to build that team, And then we will talk a lot about the pros and cons of different setups, different kinds of service providers, hurdles along the way. We really want you to leave with an idea of how to start a multidisciplinary team if that is something that you're interested in. So we will be talking extensively about next steps for setting something like this up. And then at the end, we're also going to do some breakout rooms so that all of you here can network with people in your area, in your geographic area, just to make sure that there are opportunities to work with others who are actually providing multidisciplinary services in the same place.
Okay, so good morning. This brings us to our first poll. Please indicate on the poll whether you work for a multidisciplinary practice. Yep, there's a poll. There we go. Excellent. So we're going to give it a few minutes, a few seconds here.
Can we also do the previous poll? I don't know if we had enough time on that one for the people interested in the breakout groups.
Yeah, I can open it back up after this one.
Okay.
Excellent. All right, a few more seconds. So it looks like it's almost an even split between people who indicated 42% of you indicated that you do work for a multidisciplinary practice, and 56% indicated that you do not. So hopefully by the end of the workshop today, more of you will be interested in perhaps starting or joining a multidisciplinary practice. Thank you. Okay.
So I forgot to mention before the attendees, the split, and it looks like we have mostly ABA professionals. So you could be an RBT, a BCBA, anyone providing ABA. Another large chunk of psychologists, which is great. A lot of social workers, and then not specified. So the not specified could be PT, OT, speech, psychiatry, neurology, genetics, could be anything, which is awesome because that's really what we want. And that it's not surprising that we have a lot of psychologists and social workers and BCBAs because that's the work that we do here. I'm going to talk sort of the life cycle of how we got to where we are because it didn't just happen overnight. And so this is the growth, from when I started the practice back in 2008. And I launched it. It was just myself as a psychologist seeing patients. And then we grew a little bit. We started doing a summer treatment camp, which was multidisciplinary. We had social skills training. We had behavior therapy. We had parent training. We had teachers involved. We had a nurse on staff. So there was some collaborative care going on across disciplines. And then in 2016, I hired Ariel, and Ariel, being a BCBA, introduced us to the idea of providing ABA or behavior therapy. And when that happened, it started to combine the worlds, right? The world of the BCBA and the world of the psychologist together. And that was when we really started thinking about, okay, well, where's the overlap between the disciplines? How can they benefit each other, right? And then along the way, we got involved in doing special education services, working, with students that needed remediation. So we hired special ed teachers. We even launched a commercial ABA company. So now we're working with insurance. So not just cash only, but also insurance. And then in 2022, I hired Francine, and she brought testing, neuropsych testing, into the mix. So you can see sort of a stepwise fashion of adding services on sort of organically. So we started with mental health and therapy, and then we added ABA and behavior therapy, and then we added special education services, so teachers and tutors, and then we added testing. And when we put that all together, we have MPG 360, and that's our branded version of what we do. Now, again, it's a cash model. New York City, one of the few places where you can do a cash only model. But I think this model would also work, if you were billing insurance. Obviously, there's different hurdles there, but we're going to focus mostly on building a cash model. Spoiler alert, we're going to have a conference, a multidisciplinary conference on all of these different ideas in October. We hope you come out for that. And that's going to be much bigger than just us. It's going to be all different types of models, insurance, cash, and way beyond just what we're doing. So, but I wanted to tell you sort of how we got to where we are. It doesn't happen overnight. It takes a lot of work and a lot of collaboration between different professionals. And it wouldn't have worked if I didn't have a strong relationship with Ariel and I didn't have a strong relationship with Francine, right? So you have to have people that you trust to build this house together, because you're always living in the house as you're building it, essentially. And it can be quite stressful. It's never smooth. It's never a straight line. It's always, you know, like the stock market, it's up and down, it's up and down. But as long as it's going up over time, you're okay. So I just wanted to give you guys sort of a history there.
Great. So before we get a little bit more into MPG's specific model for multidisciplinary care, I wanted to talk a little bit about, well, what is integrated multidisciplinary care, right? It's sort of a big name. All of us here, I'm sure, likely know a little bit about what it means, but what does it really mean when you get down into practice, right? So we are talking about care that starts from the place of a comprehensive assessment. So we are always coming from the angle that assessment needs to inform intervention. No matter what discipline it is, no matter how many disciplines are working together, we need to have a comprehensive assessment when we start. We're talking about multiple providers from different specialties. So today we're going to talk about MPG specific work, but in general, there's multidisciplinary work that spans medical care, speech, OT, PT, psychology services, ABA services. So there are lots of different options. One of the most really important things about multidisciplinary care is having a single point of contact to collaborate and to ensure that everyone is aligned. At MPG, we refer to that person as the quarterback. They are usually a clinician, can be really any kind of clinician, but they are in charge, right? They are shouldering the burden of making sure that everyone is talking to each other, that all the goals are, there's agreement on the goals, there's alignment on the interventions, and there's fidelity in the treatment. There's typically multiple settings of support when it comes to multidisciplinary care. In office and clinic care, community-based care, home-based care, school-based care. There are typically at least 2 settings happening when you are doing this kind of a model. Data collection and outcome tracking is critically important when you have multiple different kinds of clinicians working with the same child, with the same family. We need to make sure that we are aligned on the goals, but that everyone is measuring those goals and the outcomes in the same way, right? We do not want people working on different things at different times, because that would really be impactful to the progress of the case. It is typically a more intensive treatment schedule. So for those of us here who are psychologists working in office, usually we're talking about maybe a session or 2 a week, 45 minutes, an hour. This kind of work is far more intense. It's a higher frequency service, typically happening multiple days per week, and session times are usually longer. So what kinds of cases are usually a good fit for multidisciplinary care? Clearly, we are talking about children, adolescents, adults, individuals who need a stepped up level of care from traditional in-office therapies. Maybe they've tried that, it hasn't worked. Maybe they've tried some sort of in-school care plus the addition of in-office care, and that hasn't worked either. We are really talking about families who need more. So there's diagnostic confusion. We don't really know what's going on. There's multiple diagnoses. It's very difficult to figure out sort of the through line from diagnosis into what is currently happening and what we are seeing. School refusal is a really big one, and school refusal can be also school avoidance as well. School refusal doesn't always look like straight refusal to go to school every single day. Very, very significant externalizing behavior. There are families who are experiencing a level of physical aggression and destruction that is untenable in the home or in the community or at school. That is something that we need to have all hands on deck for. And then the last one, which is really important, is for families who are really coming from a crisis mode. They've been operating in a crisis mode for some time. They have possibly started the process of considering either residential school placement, some sort of inpatient care, and they are looking to see if there's something in between what they're currently doing and that level of having their child leave the home that they can try. So we are talking about families, about children who are really who are truly in crisis most of the time when we are considering this kind of care. So it is so important that we come at it and we approach it from a very organized place where we are able to spring into action and create a treatment plan quite quickly.
Great. And here's a visual for the multidisciplinary model that Ariel described. So as you can see, the family and the client are at the center of the intervention program alongside that clinician, that quarterbacking case manager who is working alongside the family to case manage all the collateral providers, therapists, stakeholders, anyone who is involved in the care for the client and services for the family. So where does this start? It starts with the comprehensive intake. So the first question we always ask is, has there been a comprehensive evaluation that we could use to inform our intervention plan? Is there diagnostic clarity? Do we know why this is going on? What is happening so that we could use that information to conceptualize what would work, because we're going to employ evidence-based interventions. Without that evaluation, we're left with a trial and error model. So having a comprehensive evaluation prior to the start of any kind of intervention plan is integral. Once we have the comprehensive intake and evaluation, then the quarterbacking clinician works alongside the family to organize and schedule care. And what that care is going to look like really depends on the needs of the client. It will likely include a therapeutic intervention that might be ABA and behavior therapy and or mental health psychotherapy. It might include a academic intervention such as tutoring or remediation. It might include educational coordination, such as looking for alternative learning environments or interventions that could happen in the school. There may be a medical component where there's medication management or psychiatry needed, and then additional related services such as speech, OT, and PT. And all of these services, disciplines, providers across likely different agencies, because although some of these services can occur under one roof. So for example, at MPG, we do behavior therapy and psychotherapy and testing and tutoring and educational planning. We don't provide medication management or related services. So there likely is going to be the need to coordinate care across different agencies and providers. And that is managed by the case manager or the quarterbacking clinician, who really is there to support the family who is already overwhelmed with everything that's going on with the family and with the child. So the idea of case management is very difficult, and the clinician is there to support them navigate this very challenging work.
Okay, so we're going to jump in a little bit to case studies for typical kinds of cases that have come through our practice, and talk a little bit about how we approach them at MPG, and then also some considerations to keep in mind if you're thinking about getting into this kind of work. Brenton, you can put all the stuff on the screen. Thank you. So the first I'll talk about is Liam. He is a 6-year-old boy diagnosed with ADHD per a comprehensive neuropsych. And as for the symptoms, we're talking about significant disruptive behavior at home, particularly around transitions, when he does not get what he wants, having to complete non-preferred tasks. So all of this will likely sound very familiar to any clinician here who has worked with a 6-year-old boy diagnosed with ADHD. These are concerns that come up a lot. Parents are reporting at the time of intake that the struggles are becoming quite intensive for them at home. There's a lot of aggression, destruction. Something I will note, which is very particular to New York City, is, you know, when you live and there's apartment style living, some kinds of aggression and destruction are not as tolerable as they might be in homes, right? So for those of you who are working in cities where there's a lot of people who live in apartments, you'll hear, I'm going to get kicked out of my apartment, right? The sounds are too loud, the destruction is too intense, door slamming, things like that. So we're always thinking about, well, what is specific to this case, right? It's not that there is one clear line where if the behavior exceeds that line, we're talking about this kind of care. It's really very case specific. So what are the current supports? Parents are engaged in group therapy model, a parenting group for children specifically diagnosed with ADHD. They're meeting weekly with a clinical psychologist, walking through essentially behavioral parent training on a broader scale, right? What are some ways that you can set up routines, rule structure at home? Liam also has an IEP at school. He is enrolled in an integrated co-taught classroom. He has a great list of behavior management strategies. And according to parents and to school, the behavior is quite well managed there. And I say that because it's a very important data point to note that when there is very strong behavior management in place, very strict structure, he is responsive to that, right? So that's an important data point to keep in mind as the clinician who is intaking this family. So as Josh mentioned, MPG 360 is MPG's multidisciplinary approach. And at MPG, we can provide all kinds of evidence-based psychotherapy, both in office and via telehealth. That is for the child and for the parent. We could also do comprehensive testing, as well as home-based, community-based, school-based behavior therapy, applied behavior analysis. So when we intake the family, we are clear on everything that we can offer, and we are clear with the family about what we cannot offer, but also about the ways that we are communicating and collaborating with outside service professionals. So our first step, as Francine said, intake. We're looking at the neuropsych, we're talking to the school, we're getting an idea of what is going on. Then after we meet with the family, and they walk us through all of the challenging behavior, what has worked, what hasn't worked, what they're willing to try, what they haven't tried yet, just generally speaking where they're at. The recommendations are listed here. Psychiatric consultation, initiation of a more intensive parent training model. So PMT, parent management training, is an evidence-based approach to externalizing behavior remediation, and that is something we would recommend. The next one is really important because, as Francine mentioned, we do a lot of testing, but we also do diagnostic testing, but we also do a lot of behavior-based testing. And this is a really important step that cannot be overlooked, especially for those of you who are here who are BCBAs. You know that we need to figure out the why of the behavior, right? We have the diagnosis, but we need to figure out the why. So we're going to be talking about a skills-based assessment to figure out, well, where are Liam's skills at in relation to same age peers? And then a functional behavior assessment. What's going on? Why is this behavior happening? Not just how it looks, but why. These things happen in the home, in the community with a BCBA. And from there, we're making a recommendation to initiate home-based therapy so that there are therapists on the ground working with the family to put the behavior plan into action and to work with Liam directly on skill acquisition. So if we're talking about building coping skills, things like that. All of that is probably stuff that a lot of you are here already doing, that you're familiar with. The next piece that I want to talk about is actually one of the most important pieces, and is a list of things that are important to take into consideration based on my personal experience, our experiences doing this kind of work for a number of years. Treatment plans are great. Writing an FBA, writing a BIP, many people here can do that. We can do it quite well. We went to school, we're trained to do that kind of a thing. But if you've been doing any of this work for any period of time, you know that what looks wonderful on paper does not always happen in person. And that is a big divide that we need to be thinking about and accounting for all the time. So if you are intaking a family as the quarterback, what are you looking for, right? And not just what data are you looking for, what are you looking for from the family, right? We need to assess if this is a family that is really committed to this kind of work. Sometimes, and again, this is from personal experience, particularly in New York City, when there are private schools that are very specific in the behavior that they need from the students in their classroom, will push families into doing this kind of work. And you could assess in the meeting whether the family is really on board, right? We're looking for things like, are they saying that the behavior feels overblown, that everyone is overreacting, right? Are they being realistic about what they are seeing? These are things we need to assess, because if the family is not ready to go, it doesn't matter how wonderful the intervention is. Part of the role at the beginning for the quarterback is to suss out if this family is a good fit for the practice, right? Not just if we can provide the services, but is the family going to be able to work with us? This is comprehensive care. There's a lot of interpersonal relationship that happens here, and we need to be mindful of that. Something I often say to families when I'm talking with them is either one of these two phrases. You have to jump in, 2 feet first, or you have to drink the Kool-Aid on this situation, right? It's either you're doing it or you're not. And frankly, if you are dipping a toe in, that's really as good as not doing it, right? And for all the BCBAs here, I'll often talk a little bit about intermittent reinforcement and slot machines and how that could actually make behavior worse in the long run, rather than really getting in there and fixing what the challenges that are going on. So the therapist-family relationship cannot be understated. And that starts from the beginning. It starts from how those phone calls go. It starts from how that intake meeting goes. It starts with how communicative the family is, how they get back in touch with you, how they set up their intake appointment, if they're on time to the intake appointment, right? If they take it seriously, if both parents are there, if it's a 2-parent household. These are the things that, as the clinician, you need to constantly be looking for. And something we talk about a lot as a clinical team is sometimes you just get a gut feeling that it's not going to be a good fit. And it's not objective. There's no data you can point to. It's just something that comes with experience. And I would encourage everyone who's thinking about doing this work to think about times that you've worked with families where it did not go well for one reason or another, and the gut feelings that you had along the way. As clinicians, we need to be able to trust our gut on a lot of things. It doesn't mean that it's completely not workable, but it's something that we need to be aware of. So what are some challenges that come up? Communication concerns are a huge one. Let's say the family reaches out and they reach out and they want an answer immediately. This is a true thing that happens often. You get an email, you get a call, they want to call back immediately. But then you call them back, you email them back, and they don't get back to you for 3 days after that. That is a big red flag in these sorts of situations. What about you have therapists for them. You have therapists that you want them to meet, and they're sort of wishy-washy about it. These are things to look out for as well. The second thing, and Josh mentioned that we are a cash practice, and and for the sake of full transparency, this is an expensive service, right? This is not something that every family is able to afford, and many families do come to that intake meeting quite concerned about finances. This is a real thing that we need to address head on, because unfortunately, if we start to adjust treatment plans, or we don't do as many hours or recommended because of financial constraints, that will cause a problem down the road. So as hard as it is to draw the line, we want to be able to work with families, but you need to be clear on how far you are willing to go, right? So that's something that you need to decide before you head into these intake meetings. The third one is billing confusion. Lots of providers in the mix, right? We have, at MPG, we have behavior interventionists who are therapists who are under supervision. Sometimes we'll get questions about the supervisor's billing hours, right? So you want to have language, FAQs, conversations, so that families are in the know and understand what it is that they are billing for. And the last one is goodness of a fit with a provider. For all of us here who have ever done home-based work, when you step into someone's home, the dynamic is different than when that person steps into your office to receive therapy. Goodness of fit is critically important. Now, you have to take the time to really amp up the way that you do your recruitment and your staffing to make sure that you are getting as close as possible to that goodness of fit, but it takes time. And over time, we have adjusted our practices as well, allowing trials and increased meetings with therapists and family before moving forward. And that goes both ways. The therapist has to feel comfortable going into the home, and the family has to feel comfortable having a therapist in their home if we're talking about home-based care. So these are the things to think of. You know, I'll often say to other clinicians, the devil's in the details, right? The small things are what usually cause this kind of work to fall apart. And what I'm talking about are the things that sometimes they might seem small, but they come up and they blow up in a big way that gets in the way of the care being done in the way that it's supposed to be done. So if there's anything you take away from this, I would encourage you to listen to your gut when working with a family and take that into consideration when deciding if this is going to be a right fit for your practice, because it takes a lot of work to get a case up and running, right? And you want to make sure that when you do that work, you're actually going to be able to provide the service in the long run.
Great. Absolutely. You know, that clinical judgment, that trusting your gut that you speak of is so integral to the success of the intervention, not only for the practice owner or the lead clinician, but for all clinicians and providers on the team. And that communication among providers and to that lead clinician is really the key to success. If you, as a clinician, whether you're a mental health clinician, an ABA provider, if it's not a good fit for you for whatever reason, communicate that early on to set the team up for success.
Ariel, 9 years ago, you came into the team, and now we're here. How long did it take you to get comfortable saying we were offering multidisciplinary care?
How long? Oh, years.
Right, right.
Yeah.
So that's just a, I'm going to talk about how to actually launch this later, but just keep that in the back of your mind. Like, this can take years to do successfully. So,
And there's lots of bumps.
but you should still do it. We're
It's
not
totally
dissuading you. You
worth
should
it.
still do it.
Yes, you took the words out of my mouth. It's a
Yeah.
totally worth it endeavor, right? If you feel passionately about the intersection between different kinds of care to help best support a family, it is totally worth it. But, you know, definitely learn from some of the things that we're talking about today. That's why we're doing this, but also know that it takes time. So don't get discouraged.
Great. So our second case study is a school refusal case. This is a high school senior, Jane. She has attendance issues. What we know about school refusal is it doesn't happen often overnight, right? A child or client doesn't often go from attending school every single day to non-attendance. It's usually a gradual decline. And that's what we saw here when we reviewed the history, because like so many of these cases, they're not coming to us during the gradual decline period or the rapid decline period. They come to us when they're past the point of no return. At this point, it's now after February break, and Jane is no longer attending school at all. So one of the things that we do encourage with multidisciplinary care is the sooner the better. The earlier we could provide support and provide this level of intensive wraparound care, the more likely that we will intervene quickly. So we could say that 100 times because we all know that early intervention works, and we'll continue to get clients who have, kind of exhausted all other lower level of care options and find themselves in a situation where they're stuck. They don't know what else to do, and they've come to us. Great question. I'm going to answer this now. So the question is, does multidisciplinary care have to be done in the same building, or can it be done across providers in separate offices and separate spaces? And the answer is, it absolutely can be done across different spaces, agencies, offices, disciplines. But what we're talking about here is, how do you set this up within a practice? There's never, or it's very difficult to have everyone under one roof. That's unlikely to occur. There will always be the need to collaborate with collateral providers, people with outside of your agency. But the more you're able to do within your agency, the greater control you have over the integrity of the intervention plan. And that leads to positive outcomes. So physically being in one space, in one building, that's absolutely not necessary. Being under one agency where everyone is reporting to the same quarterbacking chief clinician on the case, that is very helpful for this intervention plan to work, because then everyone's on the same page, everyone's using the same data collection methods, everyone's getting the same feedback. There's one point of contact for the parents. And that's really the key to this. The parent and the quarterbacking clinician, or the family and the quarterbacking clinician, are aligned. And then that quarterbacking clinician is the point of contact for all of the providers. So in this school refusal case, we found that the main issue for this particular client was getting up and out of the home in the morning. We did find that, based on data review, that once the client was up and out, there was no issue attending school for the whole day. It was just a matter of getting them into the school building or not. So like any other multidisciplinary case, we are going to do a comprehensive intake. That comprehensive intake will include interviews with the parents, interviews with the clients, observations when feasible, discussions with prior providers. In this particular case, we spoke to the school, we spoke to the tutor, we spoke to the parent, we spoke to the school counselor, to just really conceptualize what is going on, who are the stakeholders, why is this behavior occurring, and then you create an intervention plan. And I'm talking through this very quickly, but that comprehensive intake, that assessment piece, is really integral. I cannot stress enough how important it is to do your due diligence as the primary provider doing the comprehensive intake. You really want to make sure you dot all your I's and cross all your T's, so that when you're putting together an intervention plan and staffing it and proposing a treatment plan, we feel confident that nothing was missed or overlooked. For Jane, our high school senior, we created a treatment plan that involved 4 different providers. We had the lead clinician on the case, which was the same individual who conducted the comprehensive intake, a licensed psychologist who was going to work directly with Jane, providing psychotherapy using cognitive behavioral therapy, because anxiety was the underlying issue leading to the school refusal behavior. Then we put together an in-home plan that needed to be staffed. And we staffed the in-home plan with behavior interventionists. These are behavior therapists who would go into the home using a graduated intervention plan to support the client and the family in getting up and out of the home in the morning. We had more than one in-home provider intentionally, because with a team of in-home providers, they're able to work together to provide coverage 5 days a week, because consistency is key with any of these multidisciplinary practices. And life happens, right? People get sick, things come up. If we don't have at least 2 or more providers, we don't have anyone to cover. And then the consistency of the plan will backpedal. So having 2 or more providers was essential and is essential for any plan. And then having a second clinician on the treatment team was necessary here, because we were dealing with an adolescent who did not want to share a provider with their parent. It was really important that the parent had a separate trained professional to work with, so that both of them were able to establish trust and rapport. But that being said, the communication between both clinicians, one of them happened to be a social worker and the other one happened to be a psychologist, really was key here because they needed to maintain the trust and rapport of the parent and the client and the child, while also communicating essential information to one another to inform the intervention and the treatment plan. And that same information needed to be communicated on an ongoing basis to the behavior interventionists who are going into the home to provide the graduated support to the client to get the client up and out to school. How is all of this communication done? It's done through supervision. And as Ariel stated earlier, supervision is really key here because without that ongoing collaboration, and opportunity to review the data and adjust the treatment plan, we have everyone working independently. We need to make sure that everybody is following the same plan, that the plan, which is ultimately a living plan, it's changing daily, is updated based on the data collected on the success of the intervention plan, and that all providers and anyone involved in the case is using the same language, is on the same page, is responding in a similar fashion. And there's so many people who need to be informed here. It's not only the providers and the family, it's also the school team, which includes school administrators, teachers, counselors, and any other providers such as a in-home tutor. We have to use shared language. We have to know when to respond and when not to respond. And that all helps because it provides the client with a sound sense of what they can and cannot expect. And we know with school refusal, if the unknown is ultimately what triggers the anxiety and leads to the school refusal behavior. What is going to happen when I walk into the school building? Well, somebody has to tell the security guard, who usually says, Jane, what happened? I missed you. We haven't seen you. No, please don't even acknowledge Jane. Just let Jane walk in. Don't say anything at all. Because just saying that to Jane will make her anxious, and then she's unlikely to return to school tomorrow. So these very small details make a big difference. And that is the job of the case manager, the quarterback, who really has to control for everything internal to the intervention and external to the intervention. So in Jane's case, we were able to see gradual improvement over time, and like a successful school refusal intervention, we were able to reduce the intervention over time. And that's really important, that having that flexibility with the behavior interventionist, with the different individuals providing care, because the intervention will shift and the needs will shift. And the hope is that there will be a reduction in the level of need over time and a reduction in the service provided over time. Oops, hold on.
Okay, so how to start a program like MPG 360. So just a quick reminder again, for our program, we are providing evidence-based psychotherapy services, so psychology services, social workers, and we also have externs, postdocs, things like that. We do assessments, neuropsychological assessments, diagnostic assessments, as well as those behavioral assessments. And then we provide home-based, community-based, school-based behavior therapy services, as well as tutoring and SEED and those kinds of educational services as well. So we do not do the medication management, speech therapy, physical therapy, occupational therapy. So just talking about our program, how to start a program like this, right? So the first thing is really taking a look at the kinds of patients that you treat in your practice. Are there patients that would be a good fit for this kind of work? Patients who maybe require a stepped up level of care. I would argue that actually in the post-COVID era, there are a lot more children and a lot more families who do require some more intensive work. The next thing is developing some psychoeducation, doing resources, blog posts, linking up books and articles and posts online to really put out there, okay, well, what is this and what can families expect, right? So the more that they know what to expect, and when the resources come from the organization directly, the better. The treatment team, building the treatment team is the most important thing here, right? So for us, we started with BCBAs. I am, of course, a BCBA as well as a psychologist. So many people here are BCBAs. If you are not, a BCBA is a board certified behavior analyst. They are someone who has lots of experience in the science of behavior and the application of behavior therapy, right? So if you are not that familiar with BCBAs and you know a little bit about ABA, you might be thinking, oh, well, that's, ABA is a therapy for the autistic population. And that is not true, right? BCBAs are trained in the science of behavior. They can work with many different diagnoses and are very, very skilled in behavioral remediation of externalizing challenges. So, for example, that case we were talking about with ADHD, they are perfectly suited for that, right? So actually, a lot of the work that we do is reframing this narrative of pigeonholing BCBAs into strictly work with the autistic population, because there is just way more far-reaching implications for this kind of work. How to interview and hire a BCBA. You want to look for someone who is understanding of others' perspectives, that wants to learn about the different professions and what they do and how to collaborate together. I would argue that above all else, you're looking for that ability, that interpersonal skill, the ability to collaborate, the ability to talk to other clinicians and to talk to families in a way that makes them feel supported and that we are moving the therapy forward. We're talking about how to share and collaborate efficiently, right? So this could be not just the way that you talk, but how are you sharing resources? What kind of technology are you leveraging to make sure that everyone is aligned on the goals? How are you tracking your data? These things may seem sort of, like back burner, but they are real and they are important, and they are the things that will get in the way of the therapy being as effective as possible if you do not take the time to front load how you are doing this. Tiered service provision, very, very, very important, because like I said earlier, this is a big financial investment for families. So when I say tiered service, I'm referring to the provision of therapists, trainees who are under supervision, providing a lot of the services so that families can essentially have be able to access the services at a lower fee, but know that they're still getting a high quality of service. And then the last thing, knowing what you can and cannot offer, right? And being very, very, very clear about it. So, for example, and something I'll talk about with, other clinicians is behavior therapists, BCBAs are wonderful, right? But they are not home-based psychologists, right? They cannot treat OCD in real time. They can work with a clinician, a psychologist who has developed a treatment program. They can execute on some of those strategies, but we need to be very clear about the boundaries and the scope of all of the clinicians that you are going to bring onto the team.
So logistically, how do we set up the case? And this kind of brings us back to that picture or visual that we showed earlier, but taking it one step at a time. So the first step is always going to be the comprehensive intake and subsequent evaluations so that we can create a treatment plan, identify what type of staffing is needed in order to carry out that treatment plan, provide very clear and transparent communication to the family about who will be on the treatment team, how many hours a week do we anticipate needing to provide direct care based on the plan? How many hours of indirect care or supervision are needed or estimated to be needed per week in order to carry out the plan with fidelity? Where will services take place? Who will be involved in treatment and services? Who will be available for the providers, like the point of contact? For example, if the plan is to support the client in school, who will our school point of contact be? What type of access will we have to that person? If we're in the home, who else will be in the home? Who will be our point of contact if an issue comes up in the home? We need to really establish all of these expectations prior to the start of the intervention, and we need to document them. That way, it's discussed. We have a chance, our team has a chance, and the family has a chance to review what was discussed in a recap email that or documentation that they could read and review and process on their own time. And then they could come back with questions or concerns so that there are no surprises. And then, do we anticipate any additional assessments are needed? Was there a neuro? Was there an assessment? Or do we need to wait for an assessment to be completed before we could start the plan? Then staffing, as we've mentioned, staffing is the most essential piece. We have to not only have the staff, but the staff has to be a good fit for the particular client and case. So a therapist that might be a great fit for client A might not be a good fit at all for client B. So knowing your staff, knowing where providers' strengths and weaknesses lie, what type of cases are going to be a good fit, who has relationships with different community places, such as a provider who's worked in that school before. That might be a great fit because they've already established trust with the school staff. So knowing all of that and playing Tetris with schedules, getting everyone in place so there's overlapping care so that everyone is working in a way that makes sense and it feels like it's one plan, not a few different providers in a plan that feels very disjointed. And then we have to have these ongoing meetings, and this supervision and collaboration and coordination, those meetings should be mapped out prior to the start of the intervention. You shouldn't be at the end of day one of treatment and struggling to find time that works for everyone to connect and debrief. These should already be mapped out and scheduled so that everyone knows when they are going to have the opportunity to talk to their supervisor and how much time will be needed for those check-in calls or supervision sessions. How are we tracking data? And then who is responsible for the data collection? And then who is responsible for the data review and sharing of that data? And then when are we making data reports to who? And at what point in our intervention plan are we considering milestones so that we are adjusting the treatment plan? So how do we know we've hit a first marker and we're able to move on to the next phase of the treatment plan?
So we're getting a little short on time, so we're going to talk a little quicker so we can get through the slides and get to our breakout rooms.
Okay, so I will talk faster than I usually talk. So success, what does it look like? It looks different on every case. So that is something to definitely talk about with the team, with the family, you know, at the outset of treatment. But here are some, you know, ideas. So transitioning to a step-down service, just doing therapy in office or school services. Fading the hours systematically over time, maybe doing booster sessions here and there. Staying in the least restrictive environment for school, likewise staying in the home rather than having to go to a residential treatment. And then also generalization of the skills outside of session, home, community, and school settings. So again, all of this will be clear in the data. So collecting data. So let's do the poll question. In your practice, how many times have you worked with a student or students who would benefit from a multidisciplinary service? Okay, so we have like 3/4 at often or always, right? So this is exactly why we started doing this, right? And our instincts were correct in that there are many, 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 many families and students who would benefit from this kind of work.
Okay. And then why? What are the benefits of offering multidisciplinary support and working within this model? Treatment outcomes. this model works and we're able to reach our goals efficiently, and the client is able to improve their functioning with the support that they need in an effective manner. Access. How many individuals need a higher level of care, but not an intensive level of care, where traditional outpatient treatment just isn't enough, but residential treatment is too much? How do we address patients with multi-diagnoses, right? Somebody needs both behavior therapy and cognitive behavioral therapy. Do they need to go to two different agencies to get, it's one client, they need two different supports. They could get both supports within one agency, and then those providers can collaborate. Wraparound care. And this is something we face every single day, even in a traditional outpatient psychology practice where you are working with a child and then providing parent training, whether it's a separate parent training session or just a check-in at the end of your individual session with the parents, and you're making a recommendation and the parent says yes, and then they go home and they come back the next week and you're like, how did it go? And they stare blankly at you, or they said, oh, we tried, it wasn't successful, right? How much different would it be if you're able to say, you know what, we've tried, we made this recommendation now for a few weeks, it doesn't seem like it's working. How about we get someone in the home to help, to coach, to model? And then that next week when they came back, they're like, it was great. Somebody helped me do this because I couldn't do it alone. And then looking at things through a different lens, right? Behavior therapy is implementing behaviorally based, evidence-based behavior strategies in a way that to inform behavioral change. That's what ABA is. We have to reframe the way we look at ABA and know that behavior therapy is effective and should be carried out in a organic, naturalistic environment that makes sense for the client based on their needs at that point in time. How do we then use that science of behavior and behavioral experts, BCBAs and ABA therapists, to provide a range of services for individuals with a variety of needs, not just for autism? Okay, Ariel.
Okay,
Yeah.
so
Faster.
me faster. Oh boy. Okay, here we go. All right, pitfalls. I think I already talked about a lot of them already, right? But the demands are intensive, right? We need to make sure that everyone is on board. Again, drinking the Kool-Aid. Communication is super important. This is something we need to set up and stay on throughout. Time constraints. Sometimes we don't get a lot of time. Schools will say, like, you have a couple of months to figure out something here, or else the kid can't come back to school. Funding sources, very important, right? For us, we work with the New York City Department of Education on funding some services, as well as private pay cash, but funding and the cost can be prohibitive for lots of families. Insurance advocacy. This is a personal passion area of mine. Like I said, BCBAs, their scope is outside of autism, but we need insurance to cover ABA for diagnoses other than ASD. Stay tuned. Hopefully we'll have some sort of breakthrough on that at one point or another. And then the next is you need a real machine for hiring, recruitment, to make sure that you can staff quickly, and understanding essentially how to make money with this kind of model so that you can continue to do the work.
Very nice. Thank you. Okay. So now let's say you bought in, you drank the Kool-Aid, you're interested. Either you own your company, you're in leadership, or you're an employee there and you want to bring it to leadership. So let's start with the first one. What I would recommend is really depending on your state, knowing the way that your state is organized, the scope of practices for your state. So in New York, for example, as a psychologist, I can work with BCBAs, I can work with social workers, I can hire them, but I can't hire a psychiatrist. I can't hire a speech or PT or OT. So I have to form what's called an MSO with these other disciplines, where it's not impossible. You can do it. It's just a little bit more complicated. So you have to understand the scope of practice in your state before you just start hiring people and building out, comprehensive teams. Again, worthwhile if you have a long-term plan, totally worthwhile. You can do it, and lots of people do it, but you have to understand that. And then, if you're going to do cash or insurance, insurance is going to be more complicated. You're going to have more hurdles in terms of understanding revenue streams and profit margins, but it's still the same with cash. You're just not waiting to get paid by the insurance company. So let's say you're into it, you want to do it, but you have to sort of understand the market that you're in. So what are these kids? What are these students? What's happening to them now already? So before you begin putting together a program, where are they going now? And so you might reach out to colleagues you have, like either child psychiatrists or educational consultants, people that are seeing kids that are, requiring higher levels of support. If there's an IOP around, like you want to talk to people in your community and find out like what's happening to these kids? Where are they going? Like, is there a program out there I don't know about? And everyone will say, no, there really isn't. I really wish, we could just send them one place where they can be taken care of and the parents feel supported. And you're kind of like listening to that and you're like, oh, okay, all right. So maybe there's a need here. And then, understanding your referral sources, right? So what are your referral sources frustrated about that they don't have yet, right? So you're getting referrals from schools and from neuropsychologists or psychiatrists or educational consultants, right? So talking to them will give you information about how to build the program too. Like, oh, I'd love if I could just send it someplace where, the parents are taken care of, the kid was taken care of, they were working with the school, there was medication built in, so they didn't have to shop around to find a psychiatrist. And then you can start to put it together based on what you already have. So it's a little bit of legwork, but it's worthwhile. And then sort of getting back to hold on, not done. Getting back to one of Ariel's pitfalls, which was having the right team in place. This is very much a top-down approach. And to answer a question I saw posted is like, well, how do you know you have the right people that can be flexible and have different perspectives? So this is a top-down approach. That means that leadership has to be flexible enough to understand the limits and the strengths of the different disciplines. And if leadership does, then that will work going downwards. But if the leadership is not understanding how this model is going to be successful, and there's sort of, scarcity model and, oh, I've got to protect what I do and I don't want to share patients with other people, then like that will definitely not work. So you got to make sure your partners that you're partnering with to do this from different disciplines are all on the same page. So those are the key things that I would think about if you want to start one. And there's lots of opportunities, right? Like BCBAs love doing things that get into the mental health domain, right? And psychologists love having BCBAs can handle all of the behavioral therapy and the in-home stuff that they just can't get to. So there's a lot of synergy there, which really made sense for us. But there's a lot of things we can't do that we wish we could. We wish we had a psychiatrist on staff that we could work with. We wish we had speech and PT and OT that we didn't have to refer out to, right? So there's lots of opportunities. And from a revenue point of view, it's great to have it in-house. Internal sales and internal referrals is definitely the way to get ahead in this market, right? So if you can keep the family comfortable within your one umbrella and the referrals are just recycling through your practice, that's going to be good for everyone. Good for the family because they don't have to shop around, and then good for the practice. And then let's say you want to go to your leadership and you want to build this out. The key things that leadership are want to know is like, am I going to make more money by doing this? Absolutely, you will. You're going to diversify your revenue streams and your referral sources, which is great. You're going to build more internal referrals, which is what I talked about. And you're going to have more of an impact. Like you're going to have more time with the family. It's a more intense intervention. And we know that more intense interventions tend to work better. So that's how I would try to convince leadership. And by the way, if anyone's interested and you want to problem solve or brainstorm with me or anyone else from our team, please reach out. We're happy to do it with you. Thank you. Next slide.
Okay, so I very, very briefly, I'm not going to say the name of all of them because we don't have a lot of time, but these are some really wonderful books that really get at multidisciplinary practice, BCBA, scope of practice, and really have been, in my opinion, or our opinion, are holy grails for doing this kind of work. A great starting off point if you're looking for some books. Also blog posts, articles, podcasts.